Mendapatkan pelayanan yang aman dan sesuai standar adalah hak asasi pasien. Keselamatan pasien telah menjadi isu global yang sangat penting dan tidak bisa diabaikan. Insiden yang berpotensi untuk mengakibatkan cedera atau kematian pasien dapat terjadi di rumah sakit, puskesmas, maupun instansi pelayanan kesehatan lainnya. Padahal, insiden keselamatan pasien sebenarnya adalah sesuatu yang dapat dicegah. Pusat Riset Keselamatan Pasien atau Center for Patient Safety Research Universitas Airlangga adalah research group yang berfokus untuk meningkatkan keselamatan pasien melalui edukasi dan penelitian. Dengan visi dan misi, Pusat Riset Keselamatan Pasien membahas tentang beberapa tema strategis yang mencakup pemenuhan hak pasien, kehidupan sehat dan sejahtera, meningkatkan kualitas hidup manusia, pembangunan manusia dan masyarakat, serta manajemen kebijakan dan sistem kesehatan masyarakat. Program kerja tetap Pusat Riset Keselamatan Pasien yaitu penyelenggaraan sosialisasi atau edukasi, rekrutmen pelayanan kesehatan mitra, penelitian dasar maupun terapan, kolaborasi, publikasi di jurnal nasional dan internasional, serta kegiatan pengabdian masyarakat. Dukung perkembangan keselamatan pasien di Indonesia dengan follow akun Pusat Riset Keselamatan Pasien. Share and save lives. Mendapatkan pelayanan yang aman dan sesuai standar adalah hak asasi pasien. Keselamatan pasien telah menjadi isu global yang sangat penting dan tidak bisa diabaikan. Insiden yang berpotensi untuk mengakibatkan cedera atau kematian pasien dapat terjadi di rumah sakit, puskesmas, maupun instansi pelayanan kesehatan lainnya. Padahal, insiden keselamatan pasien sebenarnya adalah sesuatu yang dapat dicegah. Pusat Riset Keselamatan Pasien atau Center for Patient Safety Research Universitas Airlangga adalah research group yang berfokus untuk meningkatkan keselamatan pasien melalui edukasi dan penelitian.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Greetings to our Vice Dean of Faculty of Public Health Universitas Airlangga, Dr. Nyoman Anita Damayanti, Dr. Gigi M.Kes, our speakers, Dr. Mohammad Ardian Laksana SpOG M.Kes, and Professor Mohammad Afzal Mahmood. And good morning to all ladies and gentlemen in this meeting room. Welcome to the World Patient Safety Day Research Week, Day 1. I am Aisyah Rafi and I will be the MC and also moderator for today's event. Before we formally begin our agenda, we would like to welcome our Vice Dean of the Faculty of Public Health Universitas Airlangga, Dr. Nyoman Anita Damayanti, Dr. Gigi M.S., to give our opening speech and remarks. To Dr. Nyoman Anita Damayanti, the screen is yours.
Yeah, thank you. Yes, Aisyah Rahmi, very beautiful girls, yeah. Prof. Afzal, how are you, Prof? Nice to meet you, Prof.
Assalamualaikum, selamat hari ini, everyone. Nice to meet you.
Salam. Thank you, Prof. Yeah. Yes, selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. First of all, I would like to inform that our Dean apologizes because she cannot join in this event and cannot to welcome to Prof. Afzal and other participants because he has 4 classes today. Yeah, and on behalf of our Faculty of Public Health Airlangga University, I would like to welcome and thank you to audience and to all of the speakers from various countries. Yeah, in honor for us, Airlangga University, to be able to deliver this very valuable event. As we know, the COVID-19 pandemic has taught us many things, yeah, including teaching us how important collaboration is for better results. health problem as well as maternal and child health is a multi-factor problem. So the solution should be from multi-sectors. The collaboration of academics, medical and non-medical professionals, industry, government, society, and media are important to face and attack the health problem, especially in the maternal and child health. And from the data and from the result, actually we know some of the maternal death can be prevented. That's why we need to do discussion and do research, and the important thing is do action. Yeah, do action to face the problem, especially about the maternal and child health. And I think this is a very important thing. The title of the seminar, 5-day seminar, right? 5-day seminar, very important and very great seminar. This is a very important title and very important special. The title of this seminar, Act Now for Patient Safety. Yes, act now. I think don't stop at the seminar and don't stop at the discussion only. Please act now, because our community, our patient, and all of us need action. And in the era pandemic COVID, we know from the data, the maternal death very high. Maybe some of us not yet know or didn't know, we have around 700 maternal death during 2021, from January until August. This is a very sad condition. Yeah, that's why we think this is one of the seminar, one of the activity is very important. And for Dr. Afzal, Prof. Afzal, thank you for your collaboration. Yes, thank you for your cooperation, and thank you for your sharing experience, very valuable thing for us. And thank you also to Dr. Ardian. Yeah, and Dr. Ardian is one of our students at doctoral program. Yeah, and he do the research about the collaboration too. I hope Dr. Ardian success in his study. And thank you to Ms. Bu Inge, yeah, as a leader of the Research Center of Patient Safety, yeah, Bu Inge and team. And thank you too for other speakers for 5 days, yeah, for Professor Beni Cahyono and Associate Professor Mrs. Hanan Kalim and Professor Cyrus and Dr. Ardian and also Dr. Ardian, Mrs. Sifaul, yeah, Mrs. Rista Fauzianing Tias, Mrs. Elida, and all of the participants. Thank you very much, and have a great seminar. Enjoy the seminar and stay healthy and productive. Thank you for all of participants, and thank you for this event. Selamat siang. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semua.
Thank you, Dr. Nyoman, for the opening speech. Our next agenda is report from the head of Center for Patient Safety, Universitas Airlangga, to Mrs. Inga Damanti, SKM M.Kes MPH PhD. The screen is yours.
Okay, thank you so much, Aisyah. Good morning, everyone.
Morning.
Assalamualaikum warahmatullahi wabarakatuh. Yes, first and foremost, I would like to thank our honorable speakers for all the webinar series, particularly Professor Afzal Mahmood and Dr. Ardian for taking the time to support this event today. So I'm very happy that I could see Professor Afzal Mahmood again in this event. So last year I follow his full course, intensive course in public health, and it was very interesting. So thank you so much for the opportunity, and thank you so much for supporting this event. And second, I would like to thank to our Vice Dean of Academic Affairs, Ibu Dr. Nyoman Anita, and also the head of the Department of Health Policy and Administration, Dr. Ratna Dwi Wulandari, for constantly supporting and encouraging our research group to grow. So I would like to thank each of you for attending this event, so as well as the committee member who worked tirelessly to make this research festival a success. So I'm excited. I'm really glad to inform that this event is a collaboration, of the Faculty of Public Health, Faculty of Medicine, and something happened. Please, the operator, please stop the share screen. Okay, thank you. I'm sorry for the technical issue. Okay, so I'm excited and glad to inform that this event is a collaboration between Faculty of Public Health, Faculty of Medicine, Faculty of Nursing, and Faculty of Pharmacy, all of which are part of our research group, the Center for Patient Safety Research. The main goal of this event is to raise awareness about patient safety issue in Indonesia. So on this very special event, we also invite our international partners from Adelaide University and La Trobe University, Australia, Coventry University from UK, and Johns Hopkins University from United States under the Inbound and Adjunct Professor Scheme. So patient safety is a global priority. However, in some countries, such as Indonesia, a significant number of people are harmed during medical treatment. So this year, we decided to joining the WHO campaign and celebrate the World Patient Safety Day to support collective effort for safer care, which include safe maternal and neonatal care. So throughout the next 5 days, we will have presentation of various research from the member of patient safety research, and some of the research has already been completed, but some of which is still in progress. Therefore, we're seeking feedback from our foreign partner and also from all the audience. So I could report that more than 272 people have registered using the registration link. However, the Zoom ID is also shared with University Airlangga staff. So finally, this is not our one and only research festival. So we intend to make this an annual event, and we will be expecting and inviting more people to present about patient safety research, so we could contribute in improving patient safety through the research. So thank you, and I hope that you enjoy this event. Thank you so much, Aisha. Back to you.
Thank you, Mrs. Ingo, for the report. Ladies and gentlemen, before we move to our next agenda, we would like to take some pictures together for today's documentation. I would like to invite Mrs. Nyoman and our honorable speakers, and also Mrs. Inga for the documentation session. All right. For the committee, ready to take the picture? I will count on 3 then. 1, 2, 3. Smile. All right. Thank you. All right. So we'll be moving to our webinar session today. I would like to remind all the participants that you can submit questions through the chat room, and we will have Q&A session after speaker's presentation. Ladies and gentlemen, Our first speaker is Dr. Mohammad Ardian from Faculty of Medicine, Universitas Airlangga. He is also the Vice Head of Center for Patient Safety, Universitas Airlangga. His last publication is Increasing of Early High-Risk Pregnancy Detection with Proactive Intervention in Bangkalan District, Madura, Indonesia. Our first speaker will be talking about role of meta leadership on maternal health system. I would like to welcome our speaker, Dr. Ardian. The screen is yours.
Okay, thank you, Aisyah. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, the Honorable the Vice Dean, Dr. Nyoman, and the Chief of the Research Group, Ibu Inge, and the other senior staff, and also my teacher and my guru, Professor Afzal Mahmood from Adelaide University. Aisyah, can you hear my voice?
Yes, Doctor.
It's
very clear.
Okay. Thank you. Let me share my presentation. Hold on. Okay. Okay. The moderator, can you see my screen?
Yes.
Okay. It is exciting for me to present this presentation. I would like to share about the role of meta leadership on maternal health system improvement during pandemic. It is quite related with the patient safety. And the outline of this presentation will be, I would like to show you the background of the problem, the pandemic and its impact on the maternal health, and how about the maternal mortality rate in East Java. Then I would like to suggest that meta leadership is the one of the option of the solution, and I would like to explain a bit about the factor and also the aspect of the meta leadership, and I would like also to show you the implementation of meta leadership in maternal health system. When the pandemic on a rise, especially on the second wave, it happened on the June, I think in the middle of June until early of August. The pandemic also impacted to the maternal health system. Not only general COVID patients who are very difficult to find the hospital, but also for the pregnant woman who doesn't or who don't have any COVID or who is not contracted of COVID are very really difficult to find the hospital because the hospital were full. And most of the referral hospital were full because of the COVID patients. So these three pictures, these three news just show us how devastating the situations were. First, in the Gresik is quite near from Surabaya. It's only 1 hour driving from Surabaya. There was one pregnant woman die because she cannot find any hospital. In Pamekasan, in Madura, there is a pregnant woman who delivered but cannot be helped because of the hard to find a hospital. As you see here on the right side, the hospital in Sutomo Hospital, the tertiary hospital were very full because of the COVID patients. On the left graph, it reflects and it shows that when the pandemic first wave happened last year, And I think it's around in Indonesia, it's nearly 15, the peak is 15,000 a day. But in July, we have the second wave. And the pattern is quite similar with the pregnant woman with the COVID who undergo to the hospital. See on the right side, we can see the peak also on July. This is the pictures of the patient who come to the Sutomo Hospital in tertiary hospital, mostly because of the COVID, and they are several patients comes from quite far from Surabaya because the hospital in that in the origin Kabupaten was closed, so they go to Surabaya to find help for delivery the baby. See, the peak is on July and or early on August. We hope the COVID is fade away. Previously, Timothy and Robertson mentioned in his study that he estimates the pandemic and the COVID will impact to the maternal mortality rate and neonatal death. And he make a model study. He predict that there will be increasing of the maternal death because of COVID and also the indirect cost of COVID. What is the indirect cost of COVID? The indirect cost of COVID because of the substandard services and as I mentioned previously, the access to the hospital, because of the transportation, because of the economics. It impacts all of the aspects, so it contributes to the increasing of the maternal death. He just drew the framework for the effect of health system component on coverage health services. First, the availability of health workers and availability of supplies and equipment. It will impact of the provision of health services. The second is demand for health services. As you know, in the second wave is very high demand of health services. The access of health services also have a problem. It means that the utilization of health services is impacted. Overall, the coverage of health services or health system is impaired, or we can say that the coverage is declining. Of course, it will impact to the increasing of maternal mortality rate and neonatal maternity rate. I will show you in this framework. I would like to simplify the framework of the Robertson et al. And I mix it with the Hussein framework, that the coverage is decreased up to 50%, and the effect of the decrease impact on the delay of phase 1 and phase 2. What is the delay of phase 1? Delay of phase 1, the delay of the socio-cultural factors, delay to sit or to deciding to seek the care, and delay phase 2 is reaching an appropriate level of medical facility. It happened indeed, it happened. The antenatal care is decreasing, both the quality and the quantity, and natal care also decreasing, and emergency care also decreasing. It will cause the maternal mortality increase up to 39%. If it is added with the impairment of quality care, especially on pregnant women delivery services, the maternal death will increase about 60%. Does it happen? Of course. If we see this graph, it just what is that? It just show that the theory is right. When the pandemic, when the second wave happened, you see, in 2000 and 2021, the number of maternal death on first semester, only first semester, is much more higher than the whole year in 2020. It's really sad. We see the more pregnant women die, and because of COVID. According to the Dinas Kesehatan, 40% of them are COVID. So COVID is contribute a lot, but non-COVID women also died. So we should do something. So what we have to do with these things, because it's quite related with the maternal health safety. How to deal with it? So in this presentation, I will propose that the meta leadership is the one of the solution of this situation. The meta leadership framework and the practice of method have been developed after extensive research on and observation in high stress, high stakes situation. The meta leadership defined as the purpose is a connect to the intention and the work of different organizational components to achieve the shared purpose. The process of meta leadership is working without direct authority, so it works beyond the wall, beyond the hospital, and motivate others to often overlook opportunities to facilitate interaction, encourage communication, build confidence, and foster collaboration. And the outcome of the meta leadership is, by virtue or the willingness to venture beyond the usual, are able to achieve outcome that will not otherwise be realized. The meta leadership framework consists of some journal consists of three aspects: the person, the situation, and the connectivity. And all the meta leadership these factors contribute to the successful of meta leadership is time, energy, perception, behavior, system, and relationship. As I said in the previous slide, that first aspect will be the person itself. The person of meta leadership should be attributably with the sum of the leaderships on his personality. And he also acknowledged, he also recognized the situation, and he is able to deal with the situation. And the other three factors is how to lead. In this presentation, I would like to show you that the person should be able to lead up, should be able to lead the silo, should be able also to lead the connectivity or beyond that. I will explain one by one. Yeah. First, the fundamentals of meta leadership in leading up is understand to others of preservation, learn to be a good subordinate. Leading up doesn't mean that we lead our leader, no, but we contribute or we just propose to our leader about the idea and let our leader to collaborate with us to make it successful. Leading up is to remember that it requires energy from you and the boss, resulting in the most effective relationship. It must be nurtured. So I would like to underline, but in the meta leadership, leading up is not officially we became the leader of something, no, but we just propose the new idea how to solve the problem to our boss. The challenge of leading up is the factors focus on the behavior, perceptions, and the relationship. Lead the silo. Lead the silo means lead down. I think this is very conservative leadership theory, that we build and sustain the functional team. We also not forget to celebrate the success. We have to identify and resolve the conflict. We build both individual leader and system capacity, consider current and future challenge. So as a leader in hospital, in puskesmas, in other place, we have to train ourselves how to lead our subordinate. how to empower them to make this vision success. So these 5 things should be in our memory and should be practiced regularly, so our leadership school will be improving. The factors that apply to lead the silo is the energy, the behavior, the impact, and also the relationship. Lead of connectivity. Connectivity here means work to connect purpose of many individuals to achieve a greater good. I would like to give you an example that the lead connectivity in this context is like how we collaborate and connect with the Dinas Kesehatan, with the governor, with the Bupati, and convince them that our vision or this vision is important and should be supported. That's why the lead connectivity needs more leadership skill. Connectivity is being willing to risk manage consequences, recognize when shared goals are achieved, and build connectivity that will survive when key personalities move on. So I think in this pandemic era, this aspect of lead connectivity will be more important. So we have to collaborate with others, stakeholders, to make them support, to make them move, and to make this pandemic is fade away. The factors that apply is relationship, impact, and energy. Challenge is in defining event. I would like to say that right now the event is much more higher. I mean the leadership pressure in this pandemic, in this COVID era, it's much high. So I think the leaders should recognize, should be aware how to deal with this situation. I would like to have a kind of tips how to create an operational picture. First, the leader should have 3 steps. Step 1 is establish operational awareness. This thing is about how to make the people aware, how to empower the information system, empower the media and the sources, develop the process and question reliability of the information. Step 2 is creating framework to organize incoming information based on time, place, scale, scope of the event. You can use maps, graph, pictures to portray the knowledge. And step 3, based on your operational picture and incoming data, begin to develop prediction about how the event might evolve and build decision process around operational picture. In the rest of the presentation, I would like to give the insight, to give the picture of some colleagues that has implemented the meta leadership. Takes pictures coming from my colleagues from Jombang. He is the general obstetrician. He works at the Jombang Hospital, but he shows how he developed, how he lead the team inside of the hospital, even though he is not officially leader. He's just a staff member of the OBGYN, but he tried to improve and to deal with this situation. And he discussed with the director how to develop the operating theater for COVID, how to develop and how to operate the delivery room for COVID. See, this picture is quite beautiful for me because he can empower others to move and to help pregnant women, especially for COVID. And he just lead this situation internal of this the hospital.
Bob, Mas Bob, aku duwe dosen kayak Roro Fitria.
Yeah, thank you, Has. And inside the hospital, he just move out the hospital and connect with the other stakeholder like Dinas Kesehatan and Puskesmas. He just train them and give them knowledge, give them make aware, just to sustain the quality of care, to make sure that quality of care the mother still there. Also, he is very active on audit maternal death. It's really good, I think. So we can learn about what we have done in this case and what we have to improve. His name is Dr. Iwan Priyono. The other cases of the meta leadership happen in my college. He is the orthopedics, but when the pandemic happened on the first week, he just collaborate with the dean of faculty medicine and make application or IT system named COVID Hub, and he collaborate with the army. And see in this picture, he explained how the COVID Hub can help the community to find the hospital. And this is the governor. Governor really appreciate this idea and support this idea up to now. Really, this is really help the community to find the hospital much more efficient. And also the hospital can manage it much more efficient. At the last, leaders is in the center stage. Leaders will be seen by regulator. Leaders also will be watched by the hospital, macro policymaker, and other relevant unit, also the patient. The regulator want the leaders to have a good practice. The hospital would like the leaders to have the same vision, the good vision with the hospital. Of course, for the patient, the leaders should have a good service for the patient. The relevant unit, the leaders should have good partnership, and the macro policymaker need good result for the leaders, both in hospital, Puskesmas, and other place. Thank you very much. The leadership in maternal health system should be carry on. I think a good plan, as a General George S. Patton said, that a good plan violently executed now is better than a perfect plan next week. Thank you very much, ladies and gentlemen, for your attention. And I give this time to the moderator. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ardian. Before we move on to our next speaker, I would like to invite the committee to share Dr. Ardian's CV. My apologies, Doctor, that we haven't shared your CV before. So, Dr. Ardian graduated from Faculty of Medicine, Universitas Airlangga, one of doctoral students in Faculty of Public Health, Universitas Airlangga. Also, he has enormous experience in research about maternal health, nurse training, and also awards. So from the CV, we know that Dr. Ardian has achieved 3 times of Australian Fellowship Award. All right, a lot of experience.
Thank you, Aisha. I think.
Thank you, Doctor, for sharing your amazing experience and research with us. All right, so we will move on to our second speaker. Our second speaker is Prof. Mohammad Afzal Mahmood. Also has enormous experience in public health across countries like Australia, China, Saudi Arabia, including Indonesia, and many other countries. Okay. He is also Governor's Advisor to the Department of Health, East Kalimantan Province. All right. And his latest publication is about incidence of concomitant illnesses in pregnancy in Indonesia, estimates from 1990 to 2019 with projections to 2030.
Ya nanti.
All right, our second speaker will be talking about information communication between healthcare provider and healthcare facilities for effective and patient safety, need for, and examples from maternal health. And without further ado, please welcome Professor Muhammad Afzal Mahmood. Time is yours.
Assalamualaikum, selamat hari ini. Dr. Aisha, do you and others hear me?
Yeah,
Yes.
I can hear you.
So, first of all, I hope you all are keeping well. And I have heard from Dr. Ardian in Jatim and other colleagues in Kaltim that this current wave is going down, alhamdulillah. So it has decreased. So I hope it goes away and you all be safe, healthy, and well over there. So my prayers and best wishes for everyone. I would like to thank the organizers of this seminar, this webinar. Moderator, I believe coordinator is Dr. Ingi Damanti. Thank you very much. She has been in touch and advising me about the importance and what will be in it. Dr. Ardian Laksana has been a fellow researcher, so thanks to him for engaging me for these important initiatives. I'm thankful to Professor Neumann, Anita, who spoke to us very eloquently and informed us about the importance of patient safety, not only in COVID, but always. And then the leadership, all the leaders, particularly Professor Budi Santoso, a Dean, Faculty of Health Sciences at the University of Airlangga, and Professor Andian Darto, and all other, Dr. Baksono. So thank you very much for engaging me and providing me opportunity. I'm also sad at the graph shown by Dr. Ardian about maternal death number, and prior to him, even Professor Neumann mentioned that this year there has been more than 700 deaths. That's a disaster, unfortunate. We have been looking at the data about for the last 7-8 years, and the deaths were stagnant at 520, 530, and that's huge. Even 500 is a huge number, and now we have another 200 on top of that. So we must be doing something. It's just unacceptable. COVID will go away, inshallah, soon. And hopefully those women who died due to COVID, we will not have that impact in the near future. But we have a big problem in hand, and that is 500 women out of 500,000 pregnancy, which is a huge number in terms of death. And if we multiply it with 10, these are those women who suffer long-term consequences of eclampsia, hemorrhage, obstructed labor, uterine rupture, C-section, emergency C-section. So it's not only those who are dying, or that's a collective sadness at the national level, but also many more women who suffer long-term problem due to poor quality of care and insufficient safety of the patients in general in the middle and low-income countries. So that is just a preamble and about the importance of all this. And please keep letting me know if my voice wavers or it goes down, because I'm working using my phone and I'm not in a university. I'm stuck outside somewhere. So Dr. Aisha, please let me know whenever my voice or quality of voice goes down. If you have made me a host, then I would like to upload or share my slides. Okay. Dr. Ardian, do you see my slides?
Yes, yes, I can see your slide,
Okay.
Afzal.
Thank you very much. So I will try not to take too long. Have kept the slides few, have kept the slides only to the relevant Java Timur and East Kalimantan data to make it relevant to Indonesia only and particularly, and have focused only on safety and quality of care issues. And I consulted with Dr. Ingi and Dr. Ardian, and hence I focus on the information aspect of patient safety and quality of care. So single focus on information and single focus on maternal health in 2 provinces of Indonesia. I believe information is the currency in the hand of a healthcare provider. You cannot have a transaction of any sort if you do not have the currency, the money. And information is the money in the hands of a patient, in the hands of his healthcare provider, and the institution where he or she gets treated. So if the currency is not there, the money is not there, or if the money does not change hand properly, is not exchanged between the 2 people who are part of the transaction, then things won't happen in a good way, and the transaction will fail, or it will fail the person. In the case of healthcare, it's the patient who suffer because of the poor information, or poor management information, or poor communication of information. So I hope I'm able to convey this in the next few slides. So my focus is on the role of health information and healthcare information and its flow for patient safety and quality of care. And while there are many gaps in the information gathering and information flow, for example, between patient and provider, between patient and Bidan Swasta, between Bidan and Puskesmas and hospital, I will focus mainly at the hospital level, because in one presentation, we can focus only on one simple aspect so that we can think, be berfikir and do something about it. Okay, so this presentation is concerned with information gathering and management, particularly at hospitals and between hospitals. So safety and quality are hand in hand. In a way, they are 2 sides of the same coin. Safety is concerned with prevention and mitigating, decreasing the risk, errors, and the harms which happen in hospitals or in Puskesmas or by the healthcare provider. Examples are medical errors, unsafe surgeries, unsafe injection, incorrect referral, incorrect transfers of patient from one hospital to the other, unsafe blood transfusion. And in all these, information plays a key causative factors for most of these errors. And I will explain in the next few slides why I say so. So that's safety, about mitigating the risk. Quality is about doing good, improving the outcome. So unless we avoid the harm, we cannot do good. And we can, in the next slide, if I share with you here, 134 million adverse events in hospitals in the low middle income countries. 134 million, and 2.6 million deaths in 4 million low middle income country population. So you can calculate how many deaths are happening in Indonesia by extrapolating from this information. Yeah. And why hospital? Because now about 90% deaths are happening in hospitals of Indonesia when it comes to maternal deaths. For example, in 2018, when I had a look and reviewed the whole data of the Jatim province with my fellow researcher Ardian and Rizki and Dr. Arlen and others, we found out that 464 died at the hospital. They do not come in a very deteriorated condition. I assure you, that's not the situation that they come very deteriorated. They are in a salvageable condition. There are many errors, particularly information error happen, and we cannot save them because of that. So therefore, the need to focus on hospital in addition to the focus on Puskesmas. So just a bit of literature. I've already shared that there are so many, it's a huge problem, patient safety. Referrals needs to be improved. Una Campbell said in 2016, poor information transfer from hospital. Information does not get transferred, only the patient get transferred. And that's my own research, number 4. And then again, my research with my fellow friends from Surabaya is, and Tatim and Kukar is, information communication between district health and hospital. Information flow between the healthcare provider is one of the root cause of poor quality that we published this year, last year. That's our own research from Jatim. Number 4 is our research from Kaltim. And then one of my students did some research in Kutai Kartanagara and found out that if the care is coordinated and if there is effective communication, it helps decrease the problems of patient safety and improves the patient outcome. This is what her Larissa Ryan's work in Kutai Kartanagara was. And you could see the 2 big circles, interpersonal communication, that if the communication was better for women, and if there was a coordinated care, and believe me, coordination cannot happen if there is no information flow between level B hospital and level A hospital, level C hospital and level B hospital. No coordination happens without proper information flow. So you could see in Larissa's work, who did honors under my supervision in Kutai, that those women whose healthcare provider was good communicator and they were talking to each other, their pregnant women's risk was managed better. So that was a little bit about some literature. There's a huge literature, but I haven't counted over here, considering the time. Poor pregnancy outcome mostly due to suboptimal quality of care with poor communication. And I am keep emphasizing, and Dr. Ardian knows this, that I keep emphasizing on poor communication. We do not talk to each other between provider and patient, between hospital and hospital, between Puskesmas and hospital is a major cause. My 15 year in Indonesia's research, that's my one major finding. And why it happens? In provider and patient, I think there are some cultural issues. The hierarchy, the patient is not given as good importance as we should give to our brother and sister who is sitting in the patient's chair. So there are cultural issues, and patients are afraid of asking questions from their providers. We should remove that. Between hospital and Dinkas, there are structural issues. Hospital and Dinkas do not talk eye to eye. Rumah Sakit director and Dinas Kesehatan director, they are in a way separate organization. Even when they are talking to the Bapeda and others, they go parallel, they are like silos. And then district hospital to referral hospital, patient flows, information does not flow up properly. So this is summary of my work, which I will be sharing. Why we need to have this information and effective communication in maternal health? Because it's a complex situation. Every healthcare is complex, but pregnancy is even more complex because women go, this is from their house, to Dukun, to Posyandu, to private Bidan Swasta, to Puskismas, to private clinic, to Pravat, to Rumah Sakit. So there are many healthcare providers involved in this 10-month or even from pre-pregnancy to postpartum care. And the links are broken between these providers. This is another of my student worked in Bontang city. And she looked at that while women is going from place to place, all those providers do not have a mechanism of talking to each other. Information does not flow and the women fall through the cracks. One mechanism, good mechanism which Indonesian government has, and DEPKES and your DINKES has created is the Buku Kaya for mother and baby, but it's not used optimally. It can be a good information resource to communicate from one provider to the other if they write, dear Bidan, saya Objin, I have seen this, please not do this. So inadequate communication happens between provider and Bumil and between people at hospital and the primary care provider. And this book does not get used. It should be used or ought to be used. Many women transferred from frontline hospital like level C, level D, hospitals in small cities to level B or level A hospitals like Sutomo. So this is our work in Sutomo. For example, in Sutomo in 2018, 70 women died, out of which 65 arrived from smaller hospitals. And many of them came without adequate information when they were transferred from the hospital. Although the smaller hospital took permission from Sutomo that can I send, they failed to inform the details about what the patient is suffering from and why that patient was kept for so long at the smaller hospital. So this is, for example, from my research, looking at the 70 women who died in Sutomo, their data, that 12 of those women suffered serious bleeding at or before reaching the district or sub-district hospital. So when they bled when they were at the smaller hospital, they were then transferred to Sutomo, but the information about blood transfusion and how much blood is lost and how much blood is needed did not arrive at Sutomo hospital for 10 of those 12 women. Now, people at the peak hospital like Sutomo, then they have to figure out again. They were not ready because they were not informed. So this lack of information about facilities also happen. Like many women end up going to those hospitals from one Puskesmas or one hospital to another Puskesmas, another hospital incorrectly where the services is not available. For example, a Bumil suffered hemorrhage during delivery. She was transferred to a hospital which did not have blood transfusion facility, lacked adequate skill to deal with hysterectomy. Therefore, at the IGD, she had to run to another hospital. She died on the way, unfortunately. So these kind of pyramidal referral are important for cost effectiveness, but for some women, because the information is not there about which hospital can do hysterectomy, the women is sent to a hospital which is not good hospital for that woman. A 37-year-old Gravida 5 was in labor, attended by trained Bidan, who transferred her to the health center after being fully dilated for 6 hours. She was then transferred for a few hours to the district hospital. So why she was transferred to the health center when she's fully dilated and she's a Gravida 5? She's 37-year-old and she had other risk factors. Can she be handled and well managed at a Puskesmas? No. She needed to go directly to hospital. So lack of information from the hospital and from Puskesmas what and where should patient go was missing. She died. This happens because of the weak organizational links between Dinas Kesehatan and Rumah Sakit. This information has to travel on some structural links. You cannot inform each other. We cannot have person-to-person relationship. Yes, Pa Rizki can talk to Pa Prem or Pa Prem can talk to Pa Bernardus. That's fine. But at the system level, we cannot rely on individual relationship. It has to be structural and organizational link where Satomo is talking to Bangil and Bangil is talking to Dinas Kesehatan Bangil. And when there is an organized relationship, information flows better. Example of gaps in the information management. Again, another example, a woman was suspected of having high blood pressure. Lab investigation was ordered by the hospital. Lab investigation informed that she has problem, but then that information did not flow and did not was not used for follow-up. She died due to preeclampsia. And this happened in Java Timur, and that's why I have shown the broken bridge between Madura and Surabaya. Because information has to flow on a bridge, and that bridge is an organizational link. Another example is from Kaltim. A woman was sent home with a suspected placenta previa. No information for follow-up was provided. From hospital, Dari Hospital, Untuk Primary Care, Atao Dinkas, she suffered hemorrhage during delivery, at home, died. Again, another bridge is broken. And this is the Kutai Kartanagara beautiful bridge between east and west side of the Kutai Kartanagara at Tangarong city. Our own research in Kaltim and Jatim have shown that the poor information sharing and pyramidal referral are some of the reasons. There are many others, but I have wiped out those areas because today I don't want to confuse you by giving too many. Let's focus on information as an important issue. Again, another research informed that the poor communication and failure to talk to your senior and failure to talk to your junior provider within the hospital. People are not talking. Information is not flowing from resident doctor to professor doctor, from professor to bidan within the hospital. And teamwork is not happening and women are dying. So I will finish with a case study of a 27-year-old, and I will not give you any answer, and I will let you reflect on this, where the information was missing or where the information flow did not happen. 5-year history of hypertension, ANC with private midwife, 5 times. Blood pressure was noted as high at the ANC. She was sent to obstetrician 3 months before she died. Obstetrician prescribed antihypertensive medication. But she arrived at the district hospital post date. Her pregnancy was post mature, post date. Emergency C-section needed to be carried out at the district hospital. So a woman who has got 5 times ANCHE is noted for preeclampsia, has consulted Obgyn, and who has given the antihypertensive. So my question to you for your thinking is, why she arrived at a hospital post date? Why not on the date of delivery or even 2 days prior to the delivery date? And why we needed to do the C-section? Maybe we could have avoided if she had delivered on time, if she had arrived at the district hospital. And I request you not to blame the woman for not arriving on time, because I believe blame lies, or issue lies with, not blame, but issue lies with somewhere with the Obgyn, somewhere with the hospital, somewhere with the Dinkas, not with the poor woman. Okay. Whether she was not informed well, whether no one was informed in Puskesmas that there is a woman in Desa who needs to be at hospital, those kind of information are missing. She bled after 1 hour after C-section, continued bleeding. Bleeding was high. She was given transfusion of 100 cc. Her bleeding was assessed 600. She was transfused 100 cc. So was there an information gap between those who assessed the bleeding and those who transfused the blood? Yeah. She bled 4 more hours, and then they thought that the bleeding is 1 liter. Is this information correct? After C-section, when somebody is having the artery cut or bleeding from an artery, do you think that the 1 liter information is correct? Probably not. So she was planned to refer 8 hours after that. So information is not being managed here properly. She was referred 8 years after the bleeding to Sotomo Hospital, and Sotomo Hospital proved the transfer. She arrived at Sotomo. She was still actively bleeding, and she was operated then, but she died. She was bleeding because she had a bleeding from an artery, and bleeding continued, and unfortunately she died. So from Uskis Mass to frontline hospital, within the hospital, then from hospital to, there are many areas on this case study, and I will leave these slides with you people to think about where the information is missing and where the information was not handled properly. Okay, so I'll leave you with 2 suggestions. One suggestion I've already given. We need to organize the health system better. We cannot work as individuals. Dinkas needs to talk to Rumasakat. Rumasakat needs to talk to Rumasakat. There needs to be memorandums of understanding. We cannot everyone go to Bapeda and have a separate link. Somehow those links needs to be created. Teams needs to be developed. What Dr. Ardian said, the a leader's role is to develop teams. A leader is a bad leader if he works alone. A leader is not a Superman. A leader is a facilitator. He should develop teams. Okay, so these are some Kutai and some like this is Dr. Hood from Wangel, and this is Dr. Bernardus from Kutai, and this is Dr. Aspian from Balikpapan. So these are my friends, so I show their photo. Okay, and I think this is Ismi from Kutai Kartanagara, and this is my brother from Balikpapan. So build the teams, build bridges. Those broken bridges needs to be mended with proper information bricks on which people travel and reach their home safe and alive. This is beautiful bridge between Madura and Surabaya, and another beautiful bridge in Tangarang, Kutai, Kartanagara, Kaltem. Okay, so I'm thankful to all people, my friends in Kaltem, my friends in Jatim, and the governments over there in Indonesia. I'm thankful to them and my fellow researcher. And this is some literature. So thank you very much for giving me opportunity to talk to you, and I'm available for any questions. Terima kasih.
Thank you, Prof. Afzal, and also Dr. Ardian for the outstanding presentation. And now we would like to start the Q&A session. For all participants, questions can be submitted through the chat column. All right. All right, we have some questions here. I think our first 2 questions come for Dr. Ardian. Okay, the first question is about what the difference between the leader and meta leadership. How they improve leader to meta leadership. Dr. Ardian?
Okay. Yes, I can answer directly, Aisha. Yeah.
Yes, please.
Yes, thank you. These questions was brought by my senior, my colleagues, Dr. Hood. And Dr. Hood, thank you for your questions. What is the difference between leader and meta leadership? Meta leadership is like a tools. Leaders itself is a person. So it's like if you have driving a tank, or you have driving a Mercedes, the leader is a driver. the leader, and the mental leadership tools or the cars who will bring the leader to be to get the success mission. So they are those consist of three big aspects. The first aspect is about the person itself. The second about the situation, and the third is about the connectivity and collaboration. And how the improve the leader to meta leadership, according to the journal, is several factors can involve to get the leader to have a successful meta leadership. But I think practice, and also by practicing, and according to the discussion from the Kajamada said that learning from out in, it means that we just do, and after we're doing something, we learn from what we have done. That is that can make improvement of our leadership skill. That's my answer. And the second from Nuzulul, yeah, Aisha.
Yes, Doctor.
Yes. Okay. I would like to direct answer this question. It's not just the doctors. I mean it. It's for all the profession, not only doctors. Midwife can practice, can implement the meta leadership. I would like to inspire. I just want to inspire other that midwife, nurses, public health, or dinas kesehatan staff should practice meta leadership, because meta leadership is needed during this pandemic to solve this problem. Yeah. Yes.
All right. Thank you so much, Dr. Ardian, for the answer. Before we proceed to our further question, maybe I would like to ask Dr. Hood, who asked the first question. Is there any further question or further thing that we need to discuss, Dr. Hood? All right.
Sorry, Aisha, I haven't answered the second part of the previous question.
All right, Dr.
Yes,
Ardian.
this is about the authorities. Of course, there are authorities everywhere. I think Prof. Afzal will explain it, but I think the rules and the other regulation and authorities is, I think, should be there. But we have to be creative, we have to be innovative, and we have to be flexible on it. We have to translate it into the action who are very minimal to have what is that? I mean, not to bother others, but we have to find the flexible way in order in the right track, in order on the right authorities, and still in regulation form. Thank you, Aisha.
Thank you, Dr. Ardian. And from Ms. Nuzul, is there any further question or things to clarify from the question?
No, thank you. That's enough.
Thank you. All right. Next question. Okay, this is our previous question, I think. Yeah, it's been written twice. Okay, so the next question from Idawati to Prof. Afzal. What if pregnant woman doesn't do A and C with private midwife? 5 times the excuse that there are no complaints during pregnancy.
Okay. I'm not sure if I understand the question correctly, but I will try to answer. In that case study which I shared, that shows the woman is particularly keen on receiving healthcare. A woman who goes to the bidan, private atau pemerintah, or then goes to the obgyn and goes to the hospital, it shows that the woman is quite well informed, is keen on receiving care, Now the onus or responsibility lies with the health system, that we are able to provide a good, clear assessment of the risk, informing the women what can happen. So many times I have seen in my research that the risk communication is poor. We know that she is having a hypertension, but we do not inform her by spending 5 minutes that how hypertension will change into preeclampsia, how preeclampsia can change into multi-organ failure, and how she or her baby both can die. If we can sit down with the patient for 5 minutes, I believe she will not be post-dated. If we inform her that, dear, you are 37 years, you have hypertension, it can do problems for you, you must come. And then we share the information, and then we follow the information. On the expected date of delivery or few days prior to that, we make a phone call to inform the area Puskesmas that there is a female who is in very high risk and she should be delivering at hospital. That is where I think the problem was in that case, where unfortunately a woman died. And all those case studies I've shared with you are the true case studies where I personally know those people, they have died. So what if don't do ANCHE with private midwife? Doesn't matter. If she does it with Puskesmas, the sama situasi. If she does it with Bidan Swasta, it's okay. The problem happens, the difference only happens if she does not do any ANCHE. That is a different woman. But when she goes to a Bidan, whether it's a private Bidan or Swast or Pamarinta, then it's a Dinkas problem. Then we need to make sure that the information between provider and patient and between provider and provider flows very well. For that woman to be having a planned C-section. Dr. Ardian is here, Dr. Rizki is here, and other options are here. They can tell you that a planned C-section is much better than an emergency C-section. Am I right, Dr. Ardian?
Yes, you're right.
So she could have been saved. So I hope, Idawati, that I have answered your question.
Thank you, Prof. Afzal, for your answer. Maybe Dr. Ardian, any further explanation for the last question?
No, not really, but I think it will be better if Ibu Ida can ask the question. I think in Bahasa, that's okay. Yes. Maybe Aisyah will translate, or we will translate to Pak Afzal.
All right. Then I would like to invite Ibu Idawati maybe to open your camera or maybe open your mic so you can directly ask both of our speakers about the question. Yes, Idawati, are you still here with us?
Or anyone can ask question in Bahasa Indonesia and Dr. Ardian can translate it for me, or maybe Aisha, you can translate.
Yes, thank you, Prof. Afzal. For all participants, dipersilakan untuk bisa menanyakan pertanyaan, boleh dalam bahasa Inggris maupun bahasa Indonesia. You can directly raise your hand, bisa langsung raise hand saja untuk menanyakan pertanyaan. Any other question?
Saya, Mbak.
Baik, Bu Nyoman.
Ya, terima kasih.
Please.
Excuse me, Prof. Afzal. Yeah. Prof. Afzal
Yes,
seems very familiar with problem in Indonesia. Yeah, especially for Kalimantan and East Java, Prof. Yeah, from your presentation, I saw that the problem relatively similar, yeah, from year to year and until now. Yeah, my question is how to solve the problem, where or how to do or how to start. Yeah, because many problems we face here, we're facing here, and how to face the problem and how to start, and from what side, yeah, from what
Yeah.
angle, or yeah, because many, yeah.
Thank you, Professor Newman. That's a very important question. Thank you, Professor Newman. I think there are easy solutions to the problem. I know it looks very hard because we are set in some conventional way of thinking. Let me give you an example of Kutai Kartanagara. When I started, Kutai Kartanagara's mortality rate was 34 atau 334 death every year. So we started working with Parikasit Hospital and with the Dinas Kesehatan. So we brought the staff from Dinkas and from staff from Parikasit Hospital together, closer. Dr. Bernardo started working with Puskas Mas, Dr. Datta started working with Puskas Mas, Dr. Aisha working with Puskas Mas. Similarly, the Dinas Kesehatan had started working with Ibu Juli, who was the director of the Rumah Sakit. So in 4 years, we were able to reduce the mortality down to about 20 from 34, which is about 1/3 reduction, 30% or 33%. So if we apply that formula to Dinkas in Java, East Java, I think in 4-year time, inshallah, we can reduce from 500 to 300. Whereas for the last 10 years, we are stuck at 500. So what we did, number one, organization links. Number two, we improved the teamwork within the hospital. Information was not properly being handled, so we improved the modified early warning system inside the hospital. We improved the hotline between hospital and Puskas Mas. People were not having information on protocol, standard operation procedure, SOP. We put SOP everywhere in the hospital so that people don't have to look for them. And what Dr. Ardian said, we promoted leadership. We created a duck and duckling system that Obgyn is a duck and midwives are like her sisters and ducklings, okay, like a family. Talk to each other. You can talk anytime to your family. And duck is a leader, duckling is a family. So we created those 5 or 6 changes, and things started happening. Unfortunately, COVID came and mortality has gone up again, but I am 100% sure COVID go away and Kutai's mortality will go down back to the 20 or 18 per year. I think if we have planned now to work with 6 districts, Jombang, Tuban, and Bangil, and with Balikpapan, Samarinda, Dan, Kutai, Kartanagara, 6 districts, and pray to Allah, inshallah, we would like to work on those lines, and hopefully in 2-3 years time, we will see some changes. And I have a deep belief that if we talk to each other, if we flow the information, things happen. So I hope I have answered Professor Newman some ideas about how to change.
Yeah, thank you, Prof. So that's the managerial aspect. That is the important thing.
Yes, Professor, because you have fantastic doctors. You have beautiful, very highly intelligent staff. You have good bidan. You have good Kapala Puskas Mas. People have good heart. Indonesians are good people generally. It's the system which is not allowing them to work properly.
Thank you, Prof.
Thank you, Prof. Afzal. Yeah, sama-sama Bu Nyoman. Maybe another 2 questions. Yeah, I see Miss Inga raise her hand. All right, Vinga.
Dr. Ingi is raising
Yes,
hand.
okay. Yes, I'm raising hand. Can't wait to ask question while you're here. Okay, thank you. Thank you for the presentation. It was amazing for Dr. Ardian and Dr. Afzal. So my question is, in Australia, yeah, Prof. Afzal, I know that the maternal death is rare.
Yes.
And I know that we could not compare both of the system because health system in Australia and in Indonesia is very different. But so what's the thing that we could learn from Australia? Because I know that because I experienced the health system, it's very integrated and it's smooth and really good. There's no confusion. So everything is in a really good structure. So I also learned that there are some patient safety organization in Australia. For example, clinical, I forgot the one in the New South Wales, CEC, Clinical Excellence Commission, who like they have the project and they have the tools, for example, to improve the safety. And do you think would it be possible to, for example, like adopt the tool and use it in Indonesian hospital or maybe in within Indonesian context? So thank you.
Dr. Ingi, thank you very much. First, thank you for organizing this, you and your fellow Dr. Ardian and others, and the Patient Safety Center. Thank you for organizing this and for inviting me. Your question has twofold. Is two answers. Okay. Number one, think globally, act locally. We have to be context specific. Indonesia has to have its own solutions according to the level of the health system over there. I do not know if I have tips from Australia. I think there are 2-3 tips I can give. One tip I will say, please avoid that. Yeah. I say avoid, please do not create more organizations. You already have Piniakat, you already have SpOG, you already have Hoxie, you already have Patient Safety Center. So it takes a lot of energy. It squeezes you and me as professional in organizational, new organization, patient safety organization, this organization, that. Yeah? So that is my tip, number one. Do not create one more organization, please. Okay? Use the existing one. The second tip is, I think if we can somehow develop some small groups of people who understand both the technical side and the managerial side of health system in every Dinas Kesehatan. Unfortunately, fortunately, Indonesia's political system is very good. Indonesia's political system is very good. You have decentralized the districts. That's beautiful. You allow people to empower. But because districts, but there's a side effect of that. A side effect is that each district does not have the capacity to plan. The human resource like you and like Dr. Ardian and like Ismi and like all those people is not there in every district. So they are struggling. So University Airlangga can do one good thing, that they can start picking up 4, 5, 7 people in each dinkas, in each district, in Kabupaten, and invest some time and create teams. Some teams who can then work on their districts. So for example, you can pick Dr. Hood. Dr. Hood is already a leader, and give him a team. So that is my tip number one. Bring district hospital and dinkas together, facilitate a team development for the district, a team which understand the technical and managerial sides. That's my, I think if we can invest some time, I would be willing to work with, very happy to work with your center. That's one. And the other is that please invest now some time with the hospitals, because most of the problem or challenges are in the hospital. Hospitals are receiving women who can be saved, but they are working beyond their capacity. And this is a cultural issue. I have noted that many hospitals do not send the women quickly to the senior hospital because they feel that others will say, oh, you don't know how to treat this woman. So they keep the woman too long. And so please allow those friendly relationship between senior junior hospitals. So those are 2 or 3 tips, I think, and I think we can quickly go down to 250 from 500. The rest of the 250 will require social development, women empowerment, economic development, women's education, formal education. So I cannot guarantee you will reach 0 mortality, but inshallah in 5 years you will reach the 250 if you work on my formula. So I hope I have answered. Thank you, Ingi, for asking this good question. Dr. Ardian, you raised your hand. Have I answered to some extent?
Yeah, actually, you have answered my question, because previously I would like to. Can you hear me, Pausa?
Yes, yes.
Yeah, previously I would like to question almost the same with Ibu Inga, but as you know that now I and several colleagues has developed a decree from the president to decline the maternal mortality and neonatal mortality. That's why I would like to pick some your idea to put in that decree of the president.
Yeah, absolutely. I think we need to strengthen the districts. Districts are weak health system wise. So please support them. And that is the role of the provincial health department. But unfortunately, because of the system is such that the provincial health department has been cast off. So provincial health department should have a very strong team. So please support them, support the district, and do not take new ideas from Adelaide University and from this university and that university. We, the external people, confuse you. We give you many new ideas every year. Don't take too many new ideas. We know what the problem is. We know that things will work, and things will work on simple things. For example, I give you a simple example. If the team within the hospital is working as a team and can decide that this woman needs to be induced tomorrow by a team decision, that woman will be induced and she will not go into obstructed labor or delay in C-section, etc. I have seen many women are being delayed inside the hospital for induction because Obgyn is not talking to the team. Sorry, Ardian, this is not a blame on anyone. It's just that the way the system is. Similarly, we are not many women, 20% women, Dr. Ingi, 20% women now come in hospital with concomitant illness, diabetes mellitus, HIV, hepatitis, many other things. The Obgyn needs to be open up and talk to the cardiologist and internist and anesthetist as a team and make a collective decision that what we will do tomorrow. These are simple things which we can do. We don't need Afzal Mahmood from outside or John Hopkins from America. It's just a matter of political will to change these idiosyncratic practices within the hospital. I wish I had retired, because I will come to Indonesia and will spend some time with 5 hospitals to improve. Okay, so please give me best wishes so that I retire soon. Okay, sorry, I've given a longer answer, Dr. Ardian. I hope it makes sense.
Thank you, Afzal.
Yeah. Okay.
Thank you, Prof. Afzal, and also Dr. Ardian. Maybe one last question for our today's discussion session.
I would like a midwife to ask me a question. Is there a midwife in the audience?
Alright, apakah ada yang berasal dari kebidanan backgroundnya? Mungkin bisa raise hand dari teman-teman partisipan.
There are 145 people.
Ya, dari 145 orang ini mungkin ada yang dari kebidanan. Sepertinya sih pasti ada harusnya.
Or
Bapak, Ibu,
a medical student.
ya. Atau mahasiswa kedokteran mungkin. Bapak, Ibu, rekan-rekan partisipan. Silakan untuk raise hand sehingga mungkin sesi diskusi kita bisa lebih interaktif lagi. For all participants, from medical students or maybe midwives, midwifery students. Okay, no one raised their hand.
One was. Okay. So good then.
Maybe Dr. Ardian or Prof. Afzal, one last message or something for students from medical or health backgrounds.
Okay, Ardian, you first, and then I second.
Okay. Thank you, Aisha. From my presentation and from what I have learned about the maternal mortality, the aspect of leadership is quite important, and I think it's fundamental. We have sometimes you have difficulty to solve the problem because there is a lack of leader. There is a lack of leadership in the either in the puskesmas or in the hospital. In my research, from that I assessed 10 hospital in East Java, 10 hospital that has been that has trained by for PONEC, that most the PONEC system don't work because there is no initiative, and I think there is lack of leadership inside of the hospital to improve this situation. That's why I just propose, and I I campaign that leadership is one of the solution, and as students you should practice the leadership. Since the students, you have to practice the leadership and collaboration between the others profession. I think that's all, Aisha. Thank you very much.
Thank you, Doctor. Okay, from Professor Afzal.
Thank you. And dear students, you are the future leadership of this country, of Indonesia, right? A country I love, okay? And I'm actually missing Soto Banjir and Soto Makassar. So I hope the COVID goes away, and even Soto Madura as well, okay? So you are the leaders, future leader. When Dr. Ingi asked me one question about what we can learn from Australia, I gave 2 or 3 tips, what not to learn and what to learn. If I can give you one more thing to learn from Australia and countries which have developed, and that is the following. Please learn to respect the patient. A leader Ardian is the one who has a respect in each cell of his body for the fellow people, okay? And a good doctor, good obgyn, good bidan is one who has respect and love and empathy. If my sister or my daughter or my family member is unwell, I will follow her to obgyn, to hospital, back to home, then back to, so I follow. So in Australia, when a patient comes to a obgyn, or a bidan, till the time of delivery, they become like a responsible for that person. That I am responsible that this baby delivers in good way, in good health, and that this boomel is healthy at the end of this pregnancy. So wherever she goes, this person follows her. So if a woman comes to you and when she goes away, your information system should allow you to go after her and find out if she is doing well or not. Do not say that these women are ignorant and uneducated, they do not come for anche. Maybe their swami is not allowing them. Maybe their poverty is not allowing them. Maybe the distance is not allowing them. Maybe domestic violence is not allowing them. It's your responsibility to find out what happened to your patient. Okay, so you may make a little bit less money, but you will make a lot of love, and you will be a happy doctor when you sleep in night. If you make a phone call to someone who was hypertensive and has not come back to you. Hello, Ibu, you are hypertensive, you should have come back to me. Are you okay? Terima kasih. That's my tip, Aisha.
Thank you. Thank you, Prof. Afzal and Dr. Ardian. We have another 10 minutes, maybe last question. Our last question for discussion. Maybe Bu Shifa want to ask question, or my other lecturers from Universitas Airlangga.
Thank you, Aisha. Maybe last question for Dr. Afzal. Dr. Afzal, if we have health system information to develop or increase or decrease some communication in hospital or in dinas kesehatan or in puskesmas, there is some missing in the useful of the health system information in puskesmas, hospital, and dinas kesehatan. What we can improve to create or push the nakes or the health workers to use the health information system for the referral system for maternal health. Thank you.
Thank you, Saiful Leila. That's Leila?
Yes, Shifa.
Okay.
Shifa
Leila.
Afzal.
Okay, thank you. So very good question. How we can do? Maybe I have 1 or 2 examples. I shared with you that out of 12 women who were bleeding, they came to Satomo Hospital without simple information on blood. People need to learn to respect information. Information is currency. We need to respect, okay? Even in our Islam, the very first word was ikra, pad. Be educated, okay? Read, okay? You cannot read if you have not written. So even before reading, write, okay? So when people come to, when patient come, a doctor or bidan's role is to write as much as possible. If those women who went to Satomo, if we had diligently taken the record of how much blood has lost, how much colloid or crystalloid material we have given, how much blood we have given, and if we take that information, write down just a little bit like this, and then when we say Satomo Hospital, a woman is on the way, she is bleeding after the C-section, she has lost 2 liters of blood. I have given 1 liter of blood because I did not have more. So she will take 2 hours from my hospital to your hospital. In 2 hours, maybe she will lose 1 more liter. So by the time she reaches you, it will be 2 liter loss. So then Sutomo hospital doctor will be ready with the 2 bags, right? At the IGD.
Yeah.
Women come and they squeeze the blood from the blood bag into the body. Right? Simple. So that's one idea. So writing where you can and then conveying. Another example, I give very simple example. Everyone should use the pink book and write simply. Ibu Bidan, I have seen this woman. I have given antihypertensive. Please check every 15 days if this antihypertensive is working or not working. Effective communication. Simple, by pink book. And tell the patient, Ibu, this pink book is important. Take it to Bidan. Those simple things will improve, inshallah, improve many things. Simple things are the beautiful things. Am I answering your question?
Yes, Pak Afzal. And then this is a simple action that the health worker can do that, but it is really missing that a referral system in Indonesia cannot be better than what at the theory, and then implementation versus theory is the same. What that?
In this first place, yes. If Ardian, who's sitting in the polyclinic hospital, if he call back the Bidan and say, dear Puskismas Bidan, why you send me this patient without proper referral letter, without the proper information? Believe me, next time Bidan will work properly. Okay. Similarly, if Sutomo hospital say to Madura hospital, do not send me a patient without proper information. I will not accept. Okay. You are making mistake. But we do not say like this. We keep like this. We are so polite people. We are very polite people. We don't talk. So Dr. Ardian, I'm requesting Dr. Rizki and Dr. Yu that if you receive a patient without information, it's your responsibility to teach what will be the best behavior next time. If you receive a referral letter from Bidan Swasta, then you make a phone call and say, sorry, not acceptable. If you receive a patient from hospital and without any information says, sorry, bad behavior, I don't accept that. Things will change. But we are afraid of talking to each other. We want to make everyone friend. You cannot make everyone friend. So that's my humble suggestion. Again, my tip, do not ask a specialist to create a new health management information system. It will not work. Okay, don't ask more system, don't ask more organization. Work from within. And thank you very much for good questions, Saiful.
Okay, thank you, Pak Afzal.
Thank you. Assalamu alaikum.
Thank you. Thank you, Mushifa, for our last question in today's session. Okay, so before closing our session, ladies and gentlemen, I would like to conclude some important points of our webinar today. The first one, maternal death isn't directly impacted by COVID-19. It includes some other factors like health coverage. Meta leadership is important to empower, subordinate, and lead connectivity in order to solve maternal mortality rate issue. Poor pregnancy outcomes mostly due to suboptimal quality of care with poor communication, which actually can be improved to lower the maternal mortality risk. Information flow across health providers and regulators is important in this case. That's why we should build the team and bridges for this. Well, ladies and gentlemen, the event has now come to an end. Once again, we would like to thank our amazing, outstanding speakers, Dr. Ardian and Professor Afzal. Thank you so much for being with us today. We would also like to thank our participants for staying with us during this event, and on behalf of the organizers, I would like to apologize for any mistakes done throughout the event. Good afternoon, everyone, and wassalamualaikum warahmatullahi wabarakatuh.